Hello and good morning. My name is Susan Morris. I am your clinical nurse educator for the New Brunswick Heart Center. And today I am offering you a video on inotropes, positive inotropes, and vasopressors as it relates to the post-op cardiac surgery patient. So as you may have heard, our unit 5B North step down will soon be receiving patients on low doses of a drug called norepinephrine. And so in order to care for these patients, we have developed an education package for you as the registered nurse. So you're going to listen to this video, and following this video, you are going to complete 3 case studies. These case studies can be done as a group, but each nurse must submit the printed copy so that I can mark and give you some feedback as to it's not a pass or a fail thing. It's for me to assess your critical thinking and see if we need additional education materials, etc. And then the third part of your education package is going to be a buddy shift or a shadowing shift in the surgical intensive care for a number of nurses. Not everybody will, but if you feel that that is something you could benefit from, then don't be shy to ask your manager, Tammy, for that. So there will also be some learning objectives related to your shadowing day in SICU. So I'm going to share my screen with you and present a presentation to help you understand how and why we would use this medication. And so let me begin here with a PowerPoint presentation. So when we discussed this initiative, I felt very confident and feel still very confident that the nurses on 5B North are able to manage these patients. I have complete and utter faith in your knowledge and your ability. And until we get 100% comfortable with this patient population having a norepinephrine infusion, I think we'll probably go with one-to-one nursing for the first little bit, just so that you can ensure that you're measuring your CVP adequately, you've got your art line transduced, and you're watching your arterial pressure continuously, and that you understand how we might have to manipulate the drug up or down. So we're going to talk a little bit about cardiac output and assessing cardiac output. So when I think of anything hemodynamically, I think about the heart, and I think about the heart as 2 separate organs. I think about the heart as the right heart and the left heart, and they are joined together in the center by a set of lungs. And so when I think of right heart, I think of lower pressure, and when I think of left heart, I think of higher pressure. When I compare all 4 of my chambers, I always remember that my left ventricle is my workhorse. Another thing that I remember is I have no valves coming into the heart, either on the left or the right side. So if I were to place a catheter here in my superior vena cava, so here where I'm marking, or I had a catheter down here in my right atrium, the numeric value that I obtain measuring my CVP would be the same here in the superior vena cava as it would be down here in the right atrium, because there's no valve separating the 2. And so when I measure a CVP, I can do it either from my superior vena cava like I would with a slick, or if I were in an intensive care unit, I might have a pulmonary artery catheter, and that catheter has an opening that opens in the right atrium. And so I know that if I measured those numeric values, they would be the same. So the heart is two separate organs, right heart, left heart, separated or joined, however your brain thinks, by a pair of lungs. So the equation, cardiac output, is heart rate times stroke volume. And whenever you think about cardiac output, you should always first think of heart rate, because that is the first response our body has. So think about yourself. You're out for a walk and then you go up a steep incline. You need more cardiac output. The first thing your body does is increase your heart rate. Well, the same thing happens to the sick patient laying in a bed, where the sympathetic nervous system kicks in. And so we know that sinus tachycardia is always a symptom of something, whether it's fear, pain, anxiety, lack of fluid sometimes. So lack of preload can create an increased heart rate. Fever can increase your heart rate. So there are many reasons for it. And when we think about sinus tachycardia, we should think about treating the cause. Instead of giving medications like beta blockers and that type of thing, we should be looking at treating the cause. Additionally, I want you to always be conscious of the patient who comes into hospital, or we immediately start them on beta blockers. That patient does not have the ability to go into sinus tachycardia because we have given them a beta blocker. And so sometimes you need to keep that in mind when you're assessing a patient. You're like, well, gee, I wonder, they're not tachy, so we don't get overly excited. We're like, oh, well, I think he's doing okay. He's not tachycardic. But remember, how much beta blocker does he have on board? If poor Grampy takes 100 milligrams BID or even 50 milligrams BID, we're aiming for a heart rate in the 50s at rest in somebody who's beta blocked. So they may not be able to develop that rapid tachycardia that is very much a sign to us as healthcare providers that things might be not going so well. So heart rate is well understood. It's stroke volume that we don't have a good understanding of. So I'm going to go over stroke volume. So if you think, my heart contracts, and every time it does that contraction, it ejects a volume of fluid. That's called your stroke volume, the amount of fluid ejected with each systole. And it's around 70 mils, between 60 and 80. For example, there was a younger gentleman, well, I'll say in his 60s, in the coronary care unit last week. He came in, he was in significant cardiogenic shock. He was intubated, and they put in a special catheter called a Swan-Ganz catheter so that they could measure preload and afterload, and so they could measure a cardiac output. And so when we were doing the hemodynamic calculations of this patient, his stroke volume was 22 mils. So you think, gee, normally you eject 70, and all of a sudden now I'm only ejecting 22 mils. He is not meeting his metabolic demand. And so if you're not ejecting enough volume to feed your head, your heart, your kidneys, and all of your body, then your body is going to produce energy in a different fashion. And it's going to switch from aerobic to anaerobic metabolism. And so it's great that our body has the ability to generate its own energy. However, the breakdown or the metabolite of anaerobic activity produces lactic acid. And so this is going to create a metabolic acidosis in your patient. And if you remember anything from nursing school, you know that your heart does not like to be acidotic. No part of our body likes to be acidotic, but in particular, your heart hates to be bathed in an acidotic blood. So it may manifest itself by arrhythmias, often ventricular in nature, so your patient could easily fibrillate because of acidosis. So I'm going to spend a little bit of time on helping you understand how to manipulate your stroke volume in order to optimize your patient's cardiac output. So stroke volume is made up of three things. It's made up of preload, which is volume, basically. It's made up of afterload. When you think of afterload, I want you to think of the resistance that the ventricle has to overcome to eject its contents. And so when I think of afterload, I think of pressure, particularly my left ventricle, and what is my systemic blood pressure. And then contractility. When you've optimized heart rate and preload and afterload and you still have a poor cardiac output, then through the process of deduction or elimination, you have come down to it's a contractility problem. So when I think of the equation for cardiac output, it's heart rate times preload times afterload times contractility. And so if I were to think of the four determinants of cardiac output, they would be heart rate, preload, afterload, and contractility. And I state them in this order because I'm going to give you a little recipe to manipulate or to optimize your patient's cardiac output. And you're going to look at the parameters in the order that they are listed. You're going to view heart rate first, manage any complications or any problems related to that. Is the heart rate too high or too low? Then you're going to go to preload, afterload, and finally, when all else fails, we will manage or look at the contractility or lack thereof. So let's examine preload first. So the definition of preload is the ventricular stretch at end diastole. So when you think about end diastole, we know that two four-letter F words happen in diastole. And so one is feed, so our coronary blood vessels get perfused or fed during diastole. And that's why it's nice to have a patient beta block, because the longer you have in diastole, the more perfusion you can have to your heart. The second F word that happens in diastole is filling. And so your ventricles fill in diastole. So if you are at the end of diastole, just before you're going to eject your contents, your ventricle is as full as it can be. And so we look at the stretch at end diastole to give us an idea of how full or how much volume the patient has in their ventricles. And so initially I told you that we think of the heart as two separate organs. So of course you're going to have a right heart preload and a left heart preload. So on 5B North, we routinely measure right heart preload. And we do that with a slick through a central line. And so we measure it, and it's called a CVP, or a central venous pressure. So if I wanted to know what the preload of my right heart was, I would look at what my CVP is. Now, if you were working in surgical intensive care unit, where our post-op cardiac surgery patients are, you might have, and not all patients, but you might have a patient who has a pulmonary artery catheter. And from that catheter, you can also measure left heart preload. And so left heart preload will be higher than right heart preload. But again, that's not something that we measure on 5B North. One little point of interest that I want to bring forward is our patients who go to the cardiac cath lab come back with a cath report. And at the bottom, or in the comment section, it often says LVEDP equals, and it gives a numeric value. LVEDP stands for left ventricular end diastolic, so at the very end of diastole, when the ventricle is as full as it can be, left ventricular end diastolic pressure. The LVEDP is the same numeric value as a wedge pressure that you may hear being given in report from your SICU nurse. So a Swan-Ganz catheter can measure a wedge, and a wedge is very close to or equal to the left ventricular end diastolic pressure. So when you see that number there on your cath report, I want you to think, hey, that's the preload of the left heart. And if we measured a CVP, that is the preload of the right heart. And so you might be wondering, well, why don't we just take pulmonary artery catheters and put them in all patients? Well, like everything, it is a diagnostic tool that is not without complications. And so when cardiac surgery first came to the New Brunswick Heart Center, every patient had a Swan-Ganz catheter. And we came to realize that we can actually manage patients' volume status quite well by just having a simple CVP line in. Therefore, we have negated the complications related to a Swan-Ganz catheter. So on your floor, you will have a CVP. And so any patient that comes with norepinephrine infusion should have a slick through their cordis to manage or monitor their filling pressure or their preload. So that would be an expectation that all patients who come with norepinephrine, also known as Levophed, will have an arterial line for continuous BP monitoring, but also a CVP to assess volume status. So CVP can be measured in a number of ways. And so, as I say, the PA catheter will not be used on 5B North. The most effective way of managing CVP in the post-op cardiac surgery patient is through a slick. And so we know that a slick stands for single lumen infusion catheter, and it goes down through the cordis. So I want you to look at the little video up in the corner, and you can see my fist is my heart. So sitting right here, if I turn my neck over to the left, it exposes my jugular vessels. And if you look, my right internal jugular sits almost directly over top of my right atrium. And so that's why it gives me the same pressure when I look at it from the superior vena cava. It gives me the same numeric value as my right atrium. A CVP could also be measured on the side arm of a cordis. So cordis comes to a 90-degree angle. You have a tail out this way where you connect your intravenous to. So if you were able to put a three-way stopcock between your IV and your cordis and connect your CVP that way, you could measure it. The only thing is you can't monitor it continuously because your intravenous is infusing, and every time you needed to measure a CVP, you would have to turn off your intravenous. And that's why I say no vasoactive drugs can be infusing through this, because that would mean you are stopping all of your infusions to measure a CVP. And then the last way, and one way that we measure it frequently in coronary care, is if the physician has put in a triple lumen catheter. You can measure CVP on a triple lumen catheter by looking and connecting your flush system to the distal port. And we use Aero products in this building at this point in time. And so Aero products are color coded. And so the burgundy kind of reddish colored port is always the distal port. And that means the distal port is closest to the right atrium. So you can measure a CVP through the distal port of a double or triple lumen catheter. So normal preload pressures. When we think about CVP, we want to know what a normal is. So a normal textbook says 2 to 6 millimeters of mercury. The majority of our physicians in cardiac corner will be happy if the CVP is 2 to 10. And sometimes we like to push it a little bit towards that 10 mark to ensure that the patient has enough volume on board. Because the last thing you ever want to do is give a patient a vasoactive drug when they don't have enough volume in their intravascular space. So we always want to make sure that the patient is adequately volume loaded before we start giving giving medications to increase blood pressure. So people often say to me, I don't understand why CVP is measured the way it is. And so people are trying to make sense of how does a catheter sitting in the atrium measure stretch and diastole in the ventricle? Well, that's a very good question. And why wouldn't we just put a catheter in our ventricle? Well, if you've ever watched a pacemaker insertion, you'll see how angry the right ventricle gets when a catheter touches the inside of it. And what I mean by angry is ventricular ectopy, runs of PVCs. And so we don't like to put catheters in our ventricles if we can help it. So if I look at a CVP waveform, it has some components to it. And let me just get a pen here. And so I'm going to start out. A CVP waveform has 5 components to it. The A wave is the tallest wave. And the A of the wave stands for atrial contraction. And then you get this X descent. And then you have a C wave. C is closure of the tricuspid valve. And again, a drop in pressure. And then your V wave is ventricular contraction. And so when the tricuspid valve is open, so diastole, tricuspid valve is open, fluid is pouring down from the atrium into the ventricle, and if we're lucky enough to have atrial contraction, you get that last 20 to 30% of cardiac output pushed down into the ventricle. The pressure in the atrium and the ventricle are equal. And so that is why when we measure a CVP, we take the mean or the average. So we draw a line through our waveform, and that gives me the average of when the ventricle or when the tricuspid valve is open and when it's closed. So people say, I don't understand how we can measure the ventricle when we're sitting in the atrium. Well, what we do is we look at the entire waveform: atrial contraction, closure of the tricuspid valve, ventricular contraction, and we take the mean or the average. Because the pressure in our atrium and ventricle are equal at one point when the tricuspid valve is open. And so when we look at a CVP, we're taking the mean or the average. So if you look at this example right here, here is a CVP waveform. Here is your scale over here on the left-hand side. And you'll see the line has been drawn here for you. So if I were recording this, I would say that my CVP was 4. Then I would say to myself, okay, 4, that's within normal limits. But I wouldn't stop there. I would say, what has it been? Because I'm always looking for a trend. I'm never just looking for one number in isolation. So I say 4. Oh, gee, earlier it was 9. What has happened to my patient in the last hour or last 2 hours since the CVP was measured? So you should be looking, have I been given diuretics? If your pressure CVP has dropped from 9 down to 4, that means your patient has gotten rid of some volume. And so have I given Lasix to diurese this patient? Or have they diuresed on their own? So what is their urine output? Or secondly, have I given a vasodilating drug? So I'm going to take nitroglycerin, for example. Nitroglycerin does not get rid of volume, but what it does is it dilates your periphery so there's not as much blood returning to the right side of the heart. So think about what is happening with your patient. Don't measure a CVP robotically. Or let's say I had a patient whose CVP was 4, and now I've measured it an hour and a half later. I notice that my patient's heart rate has gone up, his respiratory rate has gone up. I listen to his lungs and he's got a few more crackles, and I think, oh gee, I wonder what's happening with this fella. And if I measure and I had a CVP of 4 and now my CVP is 10, I know that I have more volume in the right side of my heart. My patient is not managing that well. So a CVP is never just taken in isolation. It's married with all of the other clinical signs. So measuring a CVP is cutting the waveform in half. I'm going to tell you that as a newer or a novice nurse, I was always so stressed about how do I get to the scales on my Spacelab monitor, and how do I move my cursor up and down to measure? Well, I'm going to be honest and tell you that our Spacelab monitors do a really, really good job of looking at what the mean or the average is. And so the number that's up on the Spacelab screen is a number that you can be pretty confident in as long as you have done your zeroing and your leveling. So ensuring that your patient is level while he is in the bed allows you to quickly look up at the monitor and say, oh, his CVP is 5, okay, and he looks very stable. Or, oh, gee, his CVP is up to 10 now, and it was 5, even though I know that my normal parameters can be anywhere from 2 to 10. Don't take one number in isolation. Look at what has been happening, what is the trend with your patient, and then you can go forward. So when you think of CVP, I want you to think of volume. So then the definition of afterload is the resistance that the ventricles have to overcome, basically to open up the valve and eject their contents. So if you're sitting on the right side of the heart, your right ventricle is trying to open up the pulmonic valve and eject its contents. To be honest, we rarely pay attention to right ventricular afterload. Unless my patient has primary pulmonary hypertension, or much less commonly than left heart failure, is true right ventricular failure. When my right ventricle fails, it can be a big deal, but it doesn't often happen. The majority of the time when we talk about heart failure, it is left ventricle systolic in nature. So as a novice starting to learn all of these hemodynamic parameters, don't pay much attention to the afterload of our right heart, You also have to have a pulmonary artery catheter to actually measure it. So when we think about afterload, 99% of the time, we are referring to left ventricular afterload, because that's really the ventricle that has to overcome the significant pressure. So the left ventricle ejects its contents into systemic circulation. And so if I had a pulmonary artery catheter, I would measure something called my SVR, systemic vascular resistance. And that has a normal numeric value. But the question that's posed here that says, in the absence of a PA catheter, which will be what we expect to see on 5B North, we will not have a pulmonary artery catheter. The vital sign that we need to consider when we think about afterload is, what is our systemic blood pressure? Because here we are down here in the ventricle. So here's my left ventricle. Sorry, let me get a pen. So here's my left ventricle. Here is my aortic valve, and here is my systemic circulation. So let's say I have a blood pressure of 160 over 100. So my left ventricle has to create a pressure of at least 101 to open the aortic valve. But all that is done is open the aortic valve. So the left ventricle says, I want to get rid of my contents. I want to push them out and feed my body. And so the left ventricle has to create significant pressure to open the aortic valve and push all of that blood out to feed our body systemically. So the higher our blood pressure is, the higher the afterload. So you think, well, geez, it's really great if somebody has low afterload. Well, there is a threshold. So a blood pressure of 98 on 60 is probably a nice pressure for the left ventricle. Doesn't have to work as hard. We don't consume as much myocardial oxygen. And so it's easier for our heart to work. But we need to have enough afterload to feed our heart, our head, our kidneys, And so there's a fine line between just enough and too little, where we may have to cause some vasoconstriction and tighten our pipes. So when you think about an aorta that has a pressure of 160 over 100, it's very tight, it's vasoconstricted. But when you think of a patient who has a blood pressure of 70 over 30, it's very loose. Excuse me. But again, you have to have enough pressure to feed your head, your heart, your kidneys, and all of your tissue. So when you think of afterload, I want you to think of blood pressure. So the equipment that we use for hemodynamic monitoring, everybody is familiar with, and it's color-coded, red. If you don't have these little red buttons here that, sorry, you don't have those little red buttons on your equipment, you should have a little label right here that says arterial in red. In blue, you will have CVP/RA, because remember, they are the same pressure, but it will be in blue. That sticker is in blue. And then something that would only be seen in SICU is the yellow, which indicates a pulmonary artery catheter. So it's special tubing, it's non-compliant, so that the influence of atmospheric pressure does not skew our data. This little thing here called the manifold holds the transducers in place. And we also need to do something called leveling, which you are all familiar with, but I just want to refresh and just take a quick minute to go over a little bit about transducing and leveling a line. So if a patient comes from SICU with an ART line, or they come with the CVP, or they come with both, which is what we hope, they have to be transduced. So you can't have a pressure tubing that is not connected to your monitor. And that is for reasons of safety. So I want you to think about an ART line. So a patient has a right radial ART line. And for whatever reason, somebody makes the conscious decision to not transduce that, which would be wrong. But if you made the conscious decision to not transduce that, and you got busy with the patient in B bed, and all of a sudden A bed is hollering, and you go over and he has played with the stopcock, like we know patients do, and there is blood everywhere. A patient can exsanguinate very, very quickly. So they can lose between 250 and 500 mils of blood within a minute, depending on how high their blood pressure is. So if you had a patient who had an ART line and it was being transduced, then you would notice the ART line going flat if a stopcock was turned. The same thing with CVP. So having the CVP waveform up there tells you that the fluid is flowing in and blood is not flowing out. So it is for the safety of the patient. It is an expectation that any line that you have, any ART line is always transduced, and if you have pressure tubing connected to your slick, then you will be measuring CVP. If you have just a plain intravenous in a non-leva-fed, hemodynamically unstable patient, then you're not going to have to transduce because you're using the slick as an intravenous, not as a CVP measurement tool. So remember, accuracy of your parameters is an expectation, and the way you achieve that is by leveling the patient. And so if you do not know how to level, please ask myself, Tina, or Aaron. They will be there very quickly to help you and show you how to do that. So up here on the screen is a patient, just a picture I snapped, as you can see, many years ago, but the technology hasn't changed any. So I have my 2 heart rates, my 2 heart rhythms and my 1 heart rate, and I have my CVP, which is always going to be in blue. So when I look at this patient, I look at the whole picture. And so I say, okay, Joe's tachycardic. He's actually in atrial fib. So heart rate and rhythm should always go together. You should never have a heart rate without a rhythm associated in a cardiovascular center. And so next thing I want to know is, wonder what this guy's preload is. And so I look and I say his CVP is 11. So first thing I say is, oh, that's just a little tiny bit above normal. Okay, what has the trend been? What was he the past 4 hours, 6 hours, previous shift? And so I say, well, it looks like he has enough volume. And then I would go on and say, I wonder what my afterload is. And so here is my afterload. I say, ooh, 73 on 50. I have a low afterload. So if I didn't have my CVP in front of me, all I had was a heart rate and a blood pressure, then I might be inclined to say, oh, let's whip open that IV and give him some volume. But I've listened to his lungs, might be crackly, he might have peripheral edema, and I know that his ventricle is full because I have a CVP measurement of 11. So instead of giving this patient volume, I am going to tell the physician, calling you about Mr. Jones, he's got a heart rate of 124. He's in chronic atrial fib, so it would be very important if this were new onset atrial fib. But he's been in atrial fib, his heart rate's up to 124. I have assessed, and I think he's adequately volume loaded, or you can say he sounds a little wet. He has a CVP of 11, but I'm calling you about my blood pressure at 73 on 50. And so instead of giving this patient volume to treat his blood pressure, because we've already assessed his preload is adequate and maybe too much, I need to manage my afterload. And so this patient would be a great candidate to initiate norepinephrine on. But you can see how beneficial it is to have your CVP as an additional piece of the puzzle in this patient who's a little bit hemodynamically unstable. And so I want you to think of CVP as an additional piece of the puzzle. So again, here is just a picture of leveling. My line level, I want my bubble to be between the 2 lines. I put one end of my Carpenter level here, here on the sternum. And then the other end goes on the top of the manifold. Some of the line levels that we have, have this little orange square taped to them. That's because if I measured from the sternum down to my patient's right atrium, it would be 5 centimeters. And so I want the microchip that is in this tubing to be at the same level as my right atrium. But somebody in their infinite wisdom only built this 4 centimeters tall. And so if you do not have that little extra ball or little extra square taped to your line level, you are going to put your index finger right here between the manifold and the ruler. So your finger is going to be here to add that extra 1 centimeter to make this microchip level with the right atrium. So I know it's kind of confusing. So that little orange square is taped there. Dr. Teskey gave me a little lesson. He's always chuckling at the way I teach, some of my little idiosyncrasies, maybe some of my politically incorrect comments. And he made a comment that that little orange ball might be similar to Trump's appendage. I thought that was rather hilarious. But yeah, so if you're missing a Trump's appendage on your line level, use your finger between the manifold and the level, and that will give you the 5 centimeters you require so that everything is leveled at the right atrium. Zeroing. Zeroing is an important component, but you really only have to do this at the beginning of your shift or if you see numbers that don't make sense. Usually when you see numbers that don't make sense, it means there is air in the system. So 0, you turn it off to the patient. And so this example where it's open is off to the patient, but where the blue arrow is, it's showing you it's open to atmospheric pressure. And then you touch a button up on your Spacelab monitor that says 0. So it's like telling your husband, ignore atmospheric pressure, it is 0. And so the only pressure that the monitor is going to look at now is internal pressure, or what's happening with the patient. So let's put this together in a recipe. And before we do that, there's 2 things I want to talk about. When we say a patient's stable, we all have a mental connotation of what that means. From here on out, I want you to think of the stable patient as the patient who has enough or adequate cardiac output. But more importantly, when you say, oh, he's pretty unstable, I want you to think of inadequate cardiac output. So, oh, buddy in bed C, he's pretty unstable. That should say to you, he doesn't have enough cardiac output. And so there is a problem with one of 4 things. And you can use this equation anywhere in your career. It doesn't just have to be cardiac. You can use it in any unit that you go to, on any patient that becomes unstable, because unstable means inadequate cardiac output. And one of 4 things is wrong with him. So for example, the patient who comes in, he's a multi-trauma. Nothing wrong with his heart. He's a young man, multi-trauma. He's exsanguinating in front of you. His heart rate is very tachycardic. You're not going to treat that patient with beta blockers because he has a preload problem. He's bleeding out. Nothing wrong with his heart, but he has inadequate cardiac output because of blood loss. That is preload. So we're going to look at each of these components. I just gave you an example of a trauma patient. I want to give you a little tiny bit of understanding of why cardiac surgery patients are unique. And not just unique because that's where we work and we think they're cool and we love cardiac surgery. They are unique because many of them will develop, and it could be very mild or it could be very severe, anywhere on that spectrum, but they can develop vasoplegic shock, which is probably not something you learned about in nursing school. It's unique to cardiac surgery patients. The incidence can be anywhere from 9 to 44%. That was quoted in the literature in a couple of different sources, but nobody ever gave me the inclusion criteria for vasoplegic shock. So I don't know if the threshold was a systolic of 90 and below or a MAP of less than 60. I'm not sure what they used to qualify that shock. So 44% seems pretty large. However, on my last trip to SICU to get some case studies for you, ladies and gentlemen, it was not very difficult for me to find a patient who had some type of vasodilatation requiring the drug norepinephrine. So what shock, vasoplegic shock is a unique type of shock thought to be, and there's lots of hypotheses as to why it occurs. So it can be a combination of the surgical trauma, but specifically the cardiopulmonary bypass. And so these two things activate our systemic inflammatory system, and there is some very long and interesting discussion about the proteins, plasma proteins that get activated, all of the bradykinins that get activated that lead to vasodilatation. And so it's characterized, this type of shock is characterized by having a pretty normal cardiac output index, and that would depend on what the heart was like going into surgery, but having enough volume on board, but still having hypotension. And so systemic inflammatory response causes vasodilatation, and the degree is related to how activated that system is. So if you have a mild vasodilatation, then your systemic inflammatory system is mildly activated. So the two are in direct correlation. So the more activation of your inflammatory response, the more vasodilated you become. And so these patients have adequate or normal volumes. They just need something to squeeze their pipes to give them a little more afterload. So here's just a picture of a normal resistance or the normal blood vessel, and the patient who has a loss of vasomotor tone. And so this patient mimics septic shock very, very closely. And in septic shock, we adequately volume load the patient always. That's no different in cardiogenic shock or vasoplegic shock. You have to make sure that there is enough volume in the heart. So when it does go to contract, there is enough volume to be pushed out, because there's no sense in making a heart contract harder if there isn't enough volume in it. So looking at this patient you're going to determine, do they have enough preload? Do I have to give them more volume? And if I have adequate preload, then I have to manage their afterload, and that's usually the drug of choice is norepinephrine. Sometimes in surgical ICU, we will also use the drug vasopressin. So there is a thought that during cardiopulmonary bypass and cardiac surgery that we use up a lot of our naturally occurring vasopressin. And there is a field of study that suggests that maybe vasopressin is the better drug to be used for vasoplegic shock. Right now, we are opting to go with norepinephrine, but you don't know, that may change in years to come. So just keep that in mind, that we can give vasopressin infusions. It's a synthetic form of the naturally occurring vasopressin hormone that we have in our body. So let's look at the preload and determine, or let's look at the cardiac output equation and determine if we have enough preload, afterload, and contractility. So let's say I go into step-down unit and I look at my patient, and very quickly I say, oh, he doesn't look very good. What I mean by that is he has inadequate cardiac output, but it's kind of weird to walk in and say, oh, he has inadequate cardiac output. Usually we just say, oh, he's not looking good. But what that really means is he doesn't have enough cardiac output to meet his metabolic needs. So the very first parameter I'm going to look at is, what is his heart rate? And so I say, is his heart rate too high? I look and say, what is his heart rate? What is his rhythm? So rate and rhythm always go together. So if your heart rate is too high, your filling and your feeding time gets severely impacted. And so the faster your heart rate goes, the shorter diastole is. So your filling and your feeding are significantly impacted. So we'll talk about in a second how we're going to assess this. But if my heart rate was too high, first of all, I have to determine, is this sinus tachycardia and just a symptom of what's happening? Because remember, we do not treat sinus tachycardia with medications. And what I mean by that is rate-altering medications. So I'm not going to give beta blockers or calcium channel blockers to a patient who's in sinus tachycardia. But maybe my patient has gone into an SVT, and that is why his cardiac output has dropped. So can I try a vagal maneuver? Can I ask my patient to bear down as though he's attempting to have a bowel movement? Or can I ask him to take a deep breath in and hold it? Does that slow the rate down? Do you think my patient needs beta blockers or calcium channel blockers? If they're unstable and very fast, then maybe they need a cardioversion. That's not often the case on 5B North. But sometimes you can have the opposite, where your cardiac output drops because your heart rate has dropped. And so the two options we have are atropine and pacing. I'm never going to give a cardiac surgery patient atropine unless directed by the surgeon himself. But I can certainly pace my patient. And so we know that the equation for cardiac output is heart rate times stroke volume. If my patient doesn't have the ability to increase his own heart rate, then I can artificially do that by pacing him. So step one of this 4-step recipe for low cardiac output is look at my heart rate. If it's too high, I need to manage that, or if it's too low. And most of the time, on a cardiac surgery floor, I would say we have lower heart rates that need to be paced. We have a lot of rapid atrial fib, but the majority of that is stable. And so whenever I think of stable, I think of adequate cardiac output, and the unstable patient is inadequate cardiac output. So let's say I've assessed my heart rate and rhythm, and I think they're okay. It's maybe rate of 102, sinus rhythm. So I say, well, heart rate is not the problem. Preload, I'm going to go forward and assess that. So let's say I think I have too little preload. What are my assessment parameters going to be? I'm going to listen to my heart. I'm going to listen to my lungs. I'm going to look at my intake and output. I'm going to look at my weight, and weight is a huge, huge, huge indicator of volume. Is he thirsty? What's his skin turgor look like? Does he have jugular venous distension? What did they say about my x-ray? Hey, what's my IV rate at? And then if I have a CVP, I can add that into the mix. So what I'm going to find if my patient has too little preload is they're likely to be in a negative fluid balance. They're not going to have a weight gain. They don't have jugular venous distension. HJR absent. What that means is hepatojugular reflex. And if you palpate underneath your right hemidiaphragm, that is where your liver sits. And if you push in with the palms of your hand in that liver area, get your patient to turn his neck to the left side. And when you push in, if a patient is grossly engorged or has a lot of right-sided volume, you're going to see every time you push in on the liver, you're going to see a movement of fluid. But in a patient who is volume depleted, then you're not going to have that. When you push in on the liver, you're not going to see any jugular movement. Your lungs are going to be clear. You won't have a third heart sound, which is indicative of volume overload. You're going to have a decreased CVP, and if you were in an ICU with a PA catheter, you would have a decreased wedge. What about the patient who has too much preload? So again, you're going to do all of those assessment components. And what you're going to find is your patient will have a positive fluid balance. They'll have an increase in weight. They'll have jugular venous distension. You'll see their jugular veins up to here. They'll have a positive hepatojugular reflex. They may have peripheral and or pulmonary edema. They could have a third heart sound. They will have an increase in their CVP and or wedge. We will only be measuring CVP. So I look at my guy, I determine poor cardiac output. First thing I do is heart rate and rhythm. Second thing I do is, do they have enough volume but not too much? And so when I'm looking at treating preload issues, if it's too little, obviously I'm going to give volume. And what that volume is depends on the physician ordering. So it could be volulite, it could be albumin, it could be just plain old saline bolus. It depends on where you work and what the philosophy is. If you have too much preload, diuretics to help you eliminate it permanently, vasodilators, and the reason why we give drugs like nitroglycerin is so that it decreases the venous return to the right side of the heart. You haven't gotten rid of any volume, you have just displaced it. So it sits more in the periphery instead of returning to the heart. So let's say I've checked out my patient and man, he looks bad. Heart rate and rhythm, I don't think I need to treat that. And I look and I say, preload's not the problem. I think he has enough, not too much. But Grampy still looks bad. What am I going to do? I'm going to go to the next parameter in my recipe, which is afterload. So if I have too little afterload, basically I have hypotension. So we should always think fluid first. But again, fluid would have been managed in step 2 of the recipe. And so once you are volume loaded, you have enough volume on board, you are going to need a vasopressor. This is where we use 2 drugs. One is dopamine, the other is Levophed. And so dopamine has to be used at the moderate dose. And so we do not take that type of infusion on our floor, plus the fact that most people will not use dopamine at its moderate dose because it causes such a tachycardia. So the drug of choice is Levophed, also known as norepinephrine. In the intensive care unit, sometimes we use vasopressin or epinephrine, depending on our needs, but our frontline drug is always going to be norepinephrine. But what if I have too much afterload? That is rarely our problem. We do give a Presaline to some patients to lower their blood pressure. And if we think about the aortic stenosis patient, we actually reduce their afterload significantly by sending them for an AVR or a TAVI. So there's nothing wrong with their pipes, but the gate or the aortic valve to get out of the heart is very narrow. And so by opening up that gate, we've taken away the high afterload. So when I think of high afterload, first thing I think of is hypertension, so I need to manage that. Second thing I think about is aortic stenosis. And there's not a whole lot that I can do as a registered nurse to manage the aortic stenosis patient other than optimize him as best I can to get him ready for his AVR or TAVI. So let's say again, Grampy, we've heart rate and rhythm aren't a problem, but Grampy looks bad. We said, okay, well, he's got enough volume on board. I've started Levophed, and I've got his blood pressure up, but man, Grampy still looks bad. Through the process of elimination, contractility is his problem. And so we don't have a true measurement tool at our bedside unless somebody stuck a quick echo wand over a patient. But we do have his past medical history, which often has a previous cath, whether it was done the day before or from visits past. So an echo or a cath will tell us what his ejection fraction is. And so an ejection fraction is an idea of how well or how poor this patient's heart contracts. So a normal ejection fraction is 55 to 75%. So that means that we kick out between 55 and 75% of the blood that is in our left ventricle with every contraction. So how do we calculate that? So stroke ejection fraction is our stroke volume. So one beat, the amount of blood in one beat, divided by our end diastolic volume. So remember when we did the definition of preload, we said it's a stretch at end diastole. And so preload is what is in the ventricle at end diastole. It is the volume that's there. So let's say we have a healthy 70-year-old man, and he has a stroke volume of 70 mils. And we've assessed that on echo. And he has an end diastolic volume of 120. So before his heart goes to beat, contract, it has 120 mils in it. And then it contracts, and it kicked out 70 of those mils. So what we do is we divide the 120 into 70, and we get 0.58, or an EF of 58%. So that's how ejection fraction is calculated. How much we put out is the numerator. How much is in there when we started, or at the beginning of the contraction, and that is our preload. So a normal is between 55 and 75%. So correcting low contractility is always done with medication. And so we optimize heart rate and rhythm. Preload, we've optimized that. Afterload, we've optimized that, and we still have somebody who looks like a hurt and honey. Then we have to add a positive inotropic drug. And the two that we use in this facility are dobutamine, not to be confused with dopamine, but dobutamine. The other name for dobutamine is Dobutrex. And the other drug that we use as a pure positive inotrope is milrinone. The other name for milrinone is Primacor. And then when all else fails, epinephrine and really high dose dopamine have a positive inotropic effect. So it will never be an expectation that 5B North take epinephrine and high dose dopamine. That doesn't make sense. That puts the patient at jeopardy. However, there are a few patients who are on very low doses of either milrinone, not so much dobutamine, but milrinone is the better drug of choice in this patient population. So there are a few patients who are on very low dose positive inotropes that may potentially in the future come to 5B North. And I think that's appropriate. Again, we cherry pick these patients. It's not going to be a blanket statement, who's ever on milrinone can go to 5B North. That doesn't make sense. But we will be looking at the patients on a case-per-case basis and see, hey, this patient would benefit from going to 5B North. Just for the less noise, and it's better for the patient. An intensive care unit is a great place to be when you're very sick, but when you're starting to get better, your wake-sleep cycle is completely thrown off in an intensive care unit. It's bad enough on a regular nursing floor, but it's very bad in an intensive care unit. The noise level and the exposure to infection is much more significant in an ICU. So the quicker that we can get patients up and out of there, the better. So anticipate that probably in the next little while, after you ladies and gentlemen all become experts with Levophed, that we may start accepting patients on milrinone. And that will be the rare patient. But, look forward to that. So what we have here and what is now posted in your step-down unit are all of the drugs that we use in intensive care and soon to be 5B North. So epinephrine, like I say, will never be a drug that is used on 5B North. unless you are coding a patient, and that is in our standard algorithm. So we don't give epinephrine to a code patient unless we have a medical order for it. And in cardiac surgery patients, there's lots of evidence to say we shouldn't be giving a full milligram, but maybe something like between 100 and 300 micrograms. So between 0.1 and 0.3 milligrams. So I'm not going to touch on epinephrine. The next drug here is dopamine. And so it talks about 3 different doses of dopamine. The only dose that we accept on 5B North is the renal dose dopamine, and you ladies and gentlemen are very used to managing a patient with a dopamine infusion. The drug I want to spend a bit of time on is the norepinephrine or Levophed. And so I use the 2 names together a lot. And the reason why I do is because some physicians are very intent on calling it norepinephrine, and then other physicians very intent on calling it Levophed. And so I want to get you familiar with the name of this drug. So I really quite like this drug. It is a nice vasopressor. So when someone says, my patient is on a vasopressor, the first thing that you should think of, tightening the pipes, causing vasoconstriction. And I like it because it increases your blood pressure, but not at the expense of heart rate. So we all know that dopamine at higher doses can cause a tachycardia. I've even seen a tachycardia at lower doses. But Levophed will not do that. It causes vasoconstriction. And on your unit, you are going to have patients who are on Levophed at no more than 0.1 mic per kilo per minute. And so if you look over here in this column, you're going to see that norepinephrine / Levophed has a really, really wide dose range. You can start this infusion at 0.01 mics per kilo per minute and go all the way up to 3.0 mics per kilo per minute. That is a huge dose range. And so the fifth column over is titrating it up. So let's say your patient came to 5B North step down and they were pretty stable when they arrived. They're on a small dose of Levophed. Let's say they're on 0.02 mics per kilo per minute. And so you receive report, you get them all settled, and 3 hours later, your blood pressure has dropped. So the first thing you're going to do is you're going to go through your equation. Heart rate, preload, afterload, contractility. So first of all, you're going to find out, is heart rate my problem? No, probably not. Then you're going to assess your volume status. Has this changed? Maybe your patient needs some fluid as opposed to increasing his Levophed. But you have to assess that before you just go over and increase the Levophed infusion. You say, hey, I think his volume status is the same as when I assessed it an hour ago or 2 hours ago, and you have confidence in that, then you can say, yeah, okay, now I know that he's just a little more vasodilated and needs some vasoconstriction. And so it says here, increase by 0.02 mics every 3 to 5 minutes until you get an appropriate blood pressure. And so The reason why you can go up so quickly is because the onset of action is really rapid. There's not a lot of data out there to talk about the peak, but it acts very quickly. So what I would do if my patient was on 0.02 mics per kilo per minute, I would go over and I would increase the infusion to 0.04 mics per kilo per minute. And then I would watch my blood pressure. If you notice that you have to go up again to 0.06 and 0.08, this is when you need to notify your physician and say, hey, when I came on, his norepinephrine / Levophed infusion was going at 0.02. In the last 45 minutes, I have increased it from 0.02 all the way up to 0.08. This might get the physician thinking. He may be asking some key targeted questions to figure out what's happening with the patient. But once that patient gets to 0.1 mics per kilo per minute, then we have to determine, oh, this patient needs to go to SICU and be managed there. So don't be afraid to call your physicians, especially until you get familiar with managing this patient. But then there's the other side, the more positive side of this, is let's say a patient comes up to 5B North step down, and he's on 0.04 mics per kilo per minute. And throughout your shift, you notice that the blood pressure is increasing. Well, that means that the vasodilatory part of the vasoplegic shock is subsiding. And so maybe you can start to wean that. And so weaning, again, is done the same as titration. You can wean it down by 0.02 mics per kilo per minute, and you can do that every 15 to 30 minutes. So increasing and decreasing these medications, you can't keep that all in your head. So this will be posted up on the wall in our step down unit to help you with that process. So I know it may sound like a lot of information to keep in your brain, but remember, you're always doing that assessment: heart rate, preload, afterload, and contractility. And you're going to use Levophed for afterload improvement only. So it's a nice vasopressor. And on the sheet is also vasopressin, dobutamine, and milrinone. And so we're not going to talk about those because we're only starting with Levophed. But just know that milrinone or Primacor this is the main drug that we will use for contractility. And so you're never going to start this on your floor. And if you do start this, the intention will be to move the patient to the intensive care unit. The annoying thing about milrinone is you do have to give a loading dose. And so there's 4 doses that we usually run it at. And if your patient, let's say they came up to your floor at a low dose, it can be turned off at the lowest dose, and be aware that the duration of its effect can hang out for up to 8 hours. So it has a very long half-life. And so that's all I'll say about that medication. It's not a difficult medication to manage. It's actually quite a nice drug, and it improves your patient. The reason why I prefer milrinone over dobutamine is milrinone doesn't have near the effect on heart rate that dobutamine does. So both dopamine and dobutamine increase your heart rate. So when they use them in combination in the coronary care unit, you usually see a very tachycardic response. So we're going to go through a couple of case studies to help you, and then you will have some case studies to submit to me. So keep in mind, cardiac output is heart rate times preload times afterload times contractility. So here we have Jack. Jack is a 72-year-old dude, and he gets admitted to the ICU with sepsis related to a leg infection. And so if someone said to you, Jack's blood pressure is 100/59, and you looked at this rhythm, you would say, I see a P wave there. It's a little tacky. He's sinus tach. Blood pressure is 100/59. Sweet, life is good. Let's carry on. But look what happens when you actually put your eyes on Jack. Ooh, Jack is kind of what I call a hurtin' honey. He's got dilated pupils. He's gray and cyanotic. He's got dyspnea, orthopnea. He's got some crackles, some wheezes. He's coughing. His blood pressure is 100/59. But guess what I didn't tell you? Jack's normal blood pressure is 160/100. That's significant. He feels like he's going to barf. His belly has got ascites. He's got dependent peripheral edema. His SAT is dropping. So it might only be 94, but it was 100% 2 hours ago. He's starting to get a little confused. He's got jugular venous distension. He's completely exhausted. If you're good at heart sounds, maybe you've heard an S3, indicative of volume overload. He's got an engorged liver and spleen, so I bet you when you do a hepatojugular reflex assessment on him, that when you push in this area of his upper right abdomen where his liver is, you're going to see increase or movement in the jugular vein, and particularly right because of its location right over the superior and inferior vena cava. And he's got not much urine output. And as I put my hands on him, and you have to put your hands on patients to assess them, he's cool. His pulse is weak, and he's kind of slimy. He's diaphoretic. And so when I first looked at Jack, and I said, oh, sinus tach, blood pressure is 100/59. Yeah, he's cool, he's good. And then I actually laid my eyes on him. So when I think about the recipe and I think about Jack, first of all, I say, is it heart rate and rhythm make him look the way he does? Because he has inadequate cardiac output. So think about that. Heart rate. He was sinus tach. No, I don't think heart rate and rhythm are the problem. I think heart rate is a symptom of something else that's happening. So then I go on and I say, is preload a problem? Darn, I don't have a CVP. You know what? A CVP is only an additional piece of the puzzle. All of my assessment has led me to conclude that volume overload is this patient's problem. So I think preload is this man's problem. And so how am I going to fix that? I'm going to go through these and put them as possibilities or exclude them. So when I look at the first one, dobutamine infusion, I know that dobutamine is a positive inotropic drug. And so I say, well, he might need that at a later date, but right now, I'm not sure that contractility is his problem. I think volume overload is his problem, and it could be related to poor contractility. But dobutamine is not going to be my frontline drug. So I say, well, maybe I'm going to give a beta blocker. Ooh, we never give a beta blocker to somebody who is very wet. In a coronary care unit, if somebody is admitted with beta blockers and they are in significant heart failure, we will put the beta blockers on hold until we've gotten them dried out. And then we restart the beta blockers. Post-op cardiac surgery, we give lower doses of beta blockers, so it's not as big a deal. But I'm not going to give them that as a treatment. A diuretic. Yeah, I'm thinking he might need a diuretic. But I also have to be conscious of how much I give him because his blood pressure is 100/59. I'm still going to give him the diuretic because he has enough blood pressure right now, but I can expect that he will have a drop in blood pressure because there is a connection between preload and afterload. I'm not going to give him a fluid bolus. No, he does not need that. And dopamine is going to make him more tachycardic, so no. So a fluid bolus is what I'm going to give him. And so you may be saying, well, yeah, I knew that. Yes, you did. But the reason why you knew that is because in your mind, even though you have not formalized it, you actually know the equation to improve cardiac output is heart rate times stroke volume. So this gentleman, his problem was preload. It gets a little bit more complicated the sicker the patient is. And so, correct, preload, as we have outlined in our assessment process, and this is just what I have gone through and talked to you about. So again, remember that if your blood pressure is too low, you may not be able to give a diuretic. So if Jack's blood pressure was 80/40, given the same scenario, we might have to support his blood pressure first with a little bit of norepinephrine / Levophed in order to be able to give the diuretic to get rid of his preload. So you don't want to create another problem with the treatment. So you have to be conscious of that. So here's case number 2. We have a 48-year-old female. She's complaining of shortness of breath and lightheaded. She comes into the ER. She got a blood pressure of 84/50. Clear lungs, no extra heart sounds, negative fluid balance, collapsed neck veins, and she appears very dry. So your very first instinct is, oh, let's slap an IV in her and get some fluid into her. Okay, yep, totally agree with that. Get my IV in. I might start my IV. If I'm in an ER, I have a little more liberty to adjust that rate of my IV. But if I'm a diligent nurse, I'm still going to start at the basics and say, what are the heart rate and rhythm? And when I look here, I see I have more P's than QRS's. So I measure my PR interval, and it is constant and normal all the way across, but I have these extra P's. This is second-degree heart block type 2, which always has underlying pathology related to it. So something bad is happening to this 48-year-old female. A, she's female, and B, I didn't say that she was diabetic, but she is. She's been a type 1 diabetic since age 5. Diabetics and women present cardiac-wise very differently. And so she may be having silent ischemia, but I'm very concerned about her second-degree heart block type 2. And so I think about my recipe, and I start with what is heart rate and rhythm. And so when I'm thinking about what is the cause and what is the treatment, I might do two things at once. I might say, okay, I think heart rate and rhythm are her problem right now, and I want to, as a nurse, pace her externally. If I have a physician present, he could order 0.5 milligrams of atropine, but as a registered nurse, I do not have the autonomy to go ahead and give an atropine without an order. If you have a standing order on your floor, I would also be hesitant in this scenario. I would want to notify my physician what is happening with this patient. So the safest thing for your license and the safest thing for this patient is to externally pace them. But I'm also going to give her a little bit of volume because I also think she has a combo preload and heart rate problem. And so I'm going to give her a little bit of volume in addition to pacing her. Do I think preload is the primary problem? No. I think the heart rate and rhythm are the primary problem, and my very first thing would be to find out why. I would do a 12-lead ECG. Is this patient suffering from ischemia? Is this patient taking any medication? So as the 12 leads being done, I am investigating her home medications. I'm also asking her about recreational drug use. And so quickly, I have brought her improved cardiac output by pacing her, improving her heart rate. So that fixed that lady very quickly. It all sounds so simple, doesn't it? Okay, so we treated this patient's heart rate and rhythm and their preload. So last case, post-op day 1, Joe comes up to your floor. He's a cabbage ×5. You receive a report from the ICU, and patient basically had an uneventful night and he's fine. It's funny, you often hear that, he's fine. Oh, or his blood pressure just dropped in the elevator. Coming from an old ICU nurse, we don't transfer patients out who are unstable to begin with. It is true, patients' blood pressures drop in the elevator. So we all kind of have a little running joke about that, but it's true. So the heart rate is 88 and it's sinus. So in the back of my mind, I think, cool, I'm happy with that. Blood pressure is 102/66. Hey, cool, I'm happy with that. He's breathing fine. His sats are fine on 4 liters. He's even got a CVP that's 8. Normal heart sounds and his chest sounds clear. Hey, my life, my day, and step down is going to be wonderful. So a couple hours later, you notice on the monitor, hey, Buddy's heart rate's over 100 now. It was 88 when he first come up. Better go check him out. Blood pressure, it's down. It's 86/50. He's breathing much more rapidly and his sats are down. I put him on 40%. I've called my respiratory therapist and I have a wedge of 12. What's happening here? He's got coarse crackles. He has normal heart sounds, but they're difficult to assess because he's breathing so rapidly. So I've had a change in my condition. And so I can sit down and on paper, I can say, well, what is different? So this is up. Sorry, that's supposed to be an up arrow. Blood pressure is down. Why is he breathing so hard? Weird. And I have an increase in my CBP, and all of these other things are telling me that maybe volume is his problem. And so I'm going to try and figure out from my recipe what's happening. Sorry. So, heart rate and rhythm, I don't think they're the primary problem. I think his heart rate is tacky now, but a symptom of something. And so when I look at preload, everything points to volume overload in this patient. So his CBP has gone from 8, now it's 12. But that is also confirmed by he's breathing more rapidly, he's got some more crackles in his lungs, his heart rate has gone up. And so I think volume overload is his problem. Maybe. So who wants to give this patient a bolus? If you look back here, his blood pressure is 86 on 50. So I'm pretty hesitant to give this guy some some diuretic, because he's a little volume overloaded. So when I look at my treatment options, I know that fluid bolus is not an option. And so I put Lasix as a yes, I would like to give. But I'm hesitant to give. I don't want to give him dopamine at 10 mics per kilo per minute. That's going to make him even more tachycardic. I don't need to pace him. He's already sinus tach. So then I have Levophed and Milrinone left. Levophed is going to increase my blood pressure, and Milrinone is going to increase my contractility. But I always want to fix afterload before I fix contractility. So the treatment of choice here would be to get this patient started on a Levophed infusion so that I could give him some Lasix to get rid of his excess volume. So do you see how patients can have combination problems? And so you never want to give a drug to cause a deterioration in condition. So sometimes you have to jump ahead to the afterload, fix and ensure that you have a good blood pressure before you get rid of excess volume. There's always the brave physician who says, yeah, I know his blood pressure is a little soft, but go ahead and give that 120 milligrams of Lasix. And so my response would be, I'm very uncomfortable with giving that amount of furosemide with that soft of a blood pressure. Could we start with 20 or 40 milligrams of Lasix and see what that does to his blood pressure? So never be afraid to challenge a physician in a professional way and tell him or her what your concerns are. Because we as nurses and they as physicians never want to cause harm to a patient. So never be afraid to voice your concern over what you might be doing to the patient. So here is an AVR. He's got a heart rate of 80, a temp of 70, and he's in chronic AFib. Respiratory rate is okay. His blood pressure is 103/54, and he's got a CBP of 9. Surprise, surprise, decreased air entry to his left lower lobe and crackles at his bases. So this describes a typical patient on 5B north. 4 hours later, we have a heart rate of 121. So up from 80. That's a pretty significant increase. Lovely blood pressure, 76 on 50. He's got a CBP of 12. He's got coarse crackles. We know that volume overload is his problem. He's tachy, his blood pressure's down, his CBP is up, and all of his physical assessment parameters tell you he's got too much preload. So preload is his problem, but again, this guy we are going to fix with Levophed first because of the low blood pressure. And so that I just wanted to reinforce that sometimes we have to give norepinephrine in order to treat preload issues. Most of the time we will use it for vasoplegic shock, which is just basically a massive or moderate or mild vasodilatation related to the systemic inflammatory response. So to finish us off, I want to just in summary say, assess your heart rate and rhythm. If it's too slow, give atropine or pacing. If it's too fast, first identify the cause. And second of all, if it's a rapid SVT, do you need beta blockers, calcium channel blockers, or even a cardioversion? If heart rate and rhythm are not your problem, go on to step 2, which is preload. If it's too little, you're going to give fluid. If it's too much, you're going to give diuretics and vasodilators as long as you have a good blood pressure. 3, you're going to assess the adequacy of afterload. If it's too low, you're going to give drugs like vasopressors, such as norepinephrine, also known as Levophed. If it's too high, you may give vasodilators, or we may transfer the patient back to ICU, put in an intra-aortic balloon pump. Not likely, but it is a possibility. Then when all of the previous parameters have been corrected, your patient's cardiac output still remains low, you're going to give a positive inotropic drug. The 2 that we use are dobutamine and milrinone. SICU may use high doses of dopamine. I hope that most places don't use that anymore. There's better drug, vasopressin or epinephrine. High-dose dopamine is rarely used anymore. So bottom line is, make sure you have an adequate heart rate. Fill the tank. Make it easy to empty the tank, so the tank being the heart. So fill it, making sure you have preload. Make it easy for the tank to empty, meaning you have an adequate blood pressure, but not too high or too low. And then when all else fails, you need a positive inotrope to squeeze the heart a little extra. So that is basically a summary of preload afterload contractility as it relates to the pharmacology of pharmacokinetic drugs that we use. So the patient who is going to be selected to go to your floor will be moderately stable. So the parameters that we have chosen is a pH of greater than 7.30. So we don't want an acidotic patient going up to 5B north. We don't want a hyperkalemic patient going, so the K of less than 5.5. We want to make sure that their urine output is greater than 15 mils an hour. The slick should be left in and connected to CBP monitoring, so make sure you have it transduced up on the screen, leveled and zeroed appropriately. And you'll have an art line which will be zeroed and leveled and always transduced. And the maximum dose of norepinephrine/Levophed that you will receive in your unit is 0.1 mics per kilo per minute. And here is the supporting evidence for this presentation. And I thank you all ladies for your ladies and gentlemen, sorry, for your attention. And now I would ask that you take out the case studies that have been left in the unit for you to do. Do those. I don't care if you do them as a group. I really don't, because group learning is wonderful. Just make sure that when you fill out the sheet, you're actually putting it into your own words and thoughts, and submit that to me. I will not be marking it, but I will give you feedback on how your critical thinking is progressing. So I thank you all very much for your time, and hope you have a good day.